If we could kill the lights, please. So the cranial nerve 4 is a trochlear nerve. And it's actually an interesting nerve. It's the only nerve, cranial nerve, that actually decussates on its approach. So basically you can see it coming out of the back of the brainstem here. And again, it kind of follows the same straight path that cranial nerve 3 travels to innervate the superior oblique muscle. And the basically the cranial nerve 4, like I said, it comes from the back here, crosses over the brainstem. It actually starts on the other side, crosses over, and kind of goes in this kind of straight path along with cranial nerve 3 and cranial nerve 6. Cranial nerve 4 depresses and rotates the eye laterally. It also intorts the eye. Innervates one muscle, this superior oblique muscle that I've highlighted here. You would do EMG from the superior oblique muscle. And again, fibers from each trochlear nerve decussate across the median plane and emerge from the back of the brainstem below the corresponding inferior colliculus, runs forward in the lateral wall of the cavernous sinus. And I'm going to put all the anatomy back together at the end of this so you can kind of see other structures that are going on here. But basically, the cavernous sinus is right here, and cranial nerve 4, 6, and 3 are kind of doing a beeline right to the orbit. And guys, I really want you to try and pay attention to these videos as I'm speaking, because it really gives you an idea of where this anatomy is. You know, so kind of look what I've highlighted, kind of the approach of these nerves. So I'm going to do this throughout the entire lecture. So injury to cranial nerve 4 results in weakness of downward eyeward movement with consequential diplopia, which is double vision. Cranial nerve 4 controls conjugate gaze. That's your ability for your eyes to move together in the same direction. So you try to get your EMG leads into this area. You know, this is a very small area, so you try to get it as close as possible to the superior oblique. Most likely you're going to be in cranial nerve 3 muscle here, because remember, it's very, very small real estate. But it's kind of, you know, kind of like a far field type EMG pickup. If you can get close enough, that's fine, because really what you're looking for is not so much, you know, spontaneous EMG from this. Is more for the triggered purposes. If you can activate it, because you want to make sure it's still working during surgery. That's why you monitor it, basically. So again, you're going to put needles up in the superior oblique here. And again, this is out of Augie Moeller's book, and he has 4 going in the same place here. Cranial nerve 6, the abducens nerve. Again, motor only. Originates in the pons beneath the floor of the 4th ventricle, emerging from the brainstem anteriorly between the pons and the medulla, as you can kind of see. And as it comes up, and actually if I stop this for a second, as it comes out of the brainstem, right around here where it kind of, again, comes in this straight movement towards the orbit, it kind of meets up with 3 and 4. They're all very close together. And again, the cavernous sinus is sitting right here. So it's going to come out much lower than cranial nerve. Cranial nerve 3 comes out of the brainstem higher. Cranial nerve 4 is coming from behind the brainstem. But they all kind of meet together and kind of go in the same trajectory to the orbit. Cranial nerve 6 innervates the lateral rectus muscle, and that's where you would do EMG. Damage to 6th nerve causes diplopia. So again, like any of these nerves, when you're doing EMG of the lateral rectus, superior oblique, medial rectus, the eye has to be moved, and you want to feel that bony ridge when you're sticking the electrode. You want to feel it scrape against the bone. But this is where I place my electrodes here, and I scrape it along the bone. You feel it, and you know, there won't be any eye damage. What you really have to worry about eye damage wise for these is not so much stick, you know, if the surgeon's going to place it, whoever places it, if you place it correctly, you're not going to damage the eye. What's going to damage the eye is just intraoperative pressure. I mean, these needles are sitting on the eye. So that's what you have to worry about. That doesn't matter who places the electrode. So again, from Augie Moeller's book, he places it here and he references it out. Sometimes I do. Such small real estate, you know, I mean, I'm showing you a picture here with 2 needles, but that's not realistic in a case like this because there's such small real estate. You're not going to put 2 needles into these muscles. You're going to put 1 needle and you can reference it off to the skin, you know, to just a bony prominence.
Kind of where the knot is, yeah, give it some slack.
Yeah. Yeah, so I would probably put maybe a thin piece of tape there, there. Let the anesthesiologist put some pads over the eyes. But you're not going to put 2 needles in these muscles. You're only going to put 1. So you can put 1 needle here, and you can, you know, put a reference down in the cheek or in the forehead, or whatever, or you can reference them off each other. But you're not going to get 2 needles into these. Now, you could also use wire loop electrodes, which are a little less invasive than EMG needles, and they're placed under the eyelids. They don't really get into the muscle, and this is them. They're super small, and you basically play, like, this is an eye. And again, this is out of Augie Moeller's book as well. We basically you can see the wire here, you can see the loop, the ring electrode here. You place it under the eyelid, kind of near the area that you want. Near the muscles, so under the eyelid, near the muscles, and you get a far field EMG potential. So when do you monitor extraocular nerves, right? That's what the question is. I mean, okay, we obviously have learned how to place them. We've learned where they are, but why monitor them and what surgeries? Skull-based tumors can invade the cavernous sinus, which is, so this is the temporal lobe here, highlighted. See this kind of behind it, this big blue kind of sac-looking thing? That's the cavernous sinus right there. And I'm going to turn this video on in a second, but if you can see here are those extraocular cranial nerves kind of coming through. So here's 3, you can see 4 coming from the back here. See how they kind of meet up? Here's 3 here, 4, and here's 6 coming up. And then they all kind of meet together to enter the orbit. So temporal lobe tumors, tumors that invade the cavernous sinus, that's when these are going to be affected. And just to show you some of the anatomy with everything kind of there. I've highlighted all the nerves here so you can see them. Kind of get an idea of what's going on here. So again, cavernous sinus, I've taken away. Bring here, so cavernous sinus, see the nerves. 4th nerve coming from the back, 3rd nerve coming from the top, 6th nerve coming from underneath. They all meet up. So any kind of tumor in this area is going to be reason to do these nerves. And honestly, the only time I've ever done extraocular nerves was on this approach to the temporal lobe. It's the only time I've done them. You don't really do them posterior fossas because you're just not accessing that high usually. Maybe 6 in a posterior fossa because 6 is actually, you know, when the way the nerves come out of the brainstem, it's really a top to bottom type thing. So 6 comes lower, near 7 and 8. So you might get into that, but the upper, you know, 4 and 3, you might not get into if you're working, you know, way down here. But temporal lobe tumors is really where, you know, you might use these EMG electrodes. So cranial nerve 5 is both a sensory and motor nerve. It originates in the pons. It's the largest cranial nerve. It's called the trigeminal nerve. It receives sensation from the face and mouth. It innervates the muscles of mastication, the masseter, the temporalis, the medial and lateral pterygoids. So basically, so here's the masseter here, temporalis, the medial and lateral pterygoids are underneath here. So a cranial nerve 5 lesion will cause pain, weakness in the face. I generally use the masseter and temporalis muscles for EMG. I think that's what we all typically do. And it's called the trigeminal nerve because it breaks into 3 different nerves. But we're only looking at the motor component of the nerve. We don't look at the sensory component. I've highlighted here the musculature. EMG electrodes in the temporalis muscle or in the masseter. If I'm doing a skull-based tumor, a posterior fossa approach, and microvascular decompression, or so on and so forth, for cranial nerve 5, and I'm monitoring it, I tend not to use the masseter. I'd rather use the temporalis muscle. It's a bigger muscle. It's not in the way. And if you're not in the masseter, then you're in cranial nerve 7 musculature. So you might be monitoring the wrong thing by going to the masseter. If you do use the masseter, because sometimes if you're doing a temporal lobe approach and you need to monitor cranial nerve 5, and obviously you can't get here if it's a temporal lobe approach, what I would do if the patient's able is I would mark them in holding with a surgical pen, have them bite down, activate that muscle, put a mark so I know where to place the needles, because once they're in the room asleep and intubated, you can't find that muscle. So just keep that in mind. I do that a lot with muscles that are harder to find when the patient's asleep. I will mark the patient in holding with a little surgical marker. It's a little X where I want to place it. I do it for the extensor digitorum brevis in the foot. It's a great muscle for motor potentials, but it's a very hard muscle to find. And it's very hard to find, especially when the patient's asleep. So in holding, I'll just put a little X there. I'll have them activate it. So if you know how to activate the muscles, have them activate the muscles. Just put a little marker, and then you can find it so you can do it effectively. Because you don't want to be in cranial nerve 7 musculature if you're also monitoring cranial nerve 7, if you want to differentiate the two. So next, cranial nerve 7. So cranial nerve 7 is also sensory and motor. It originates in the pons in the cerebellum pontine angle, CPA, near the medulla. Provides motor information to the muscles for facial expression. There's 5 branches of the nerve. There's your temporal branch, which innervates your frontalis muscle. There's your zygomatic branch, which innervates your orbicularis oculi. So your frontalis muscle is going to be here. Orbicularis oculi here. Your buccal branch, which is your orbicularis oris. Your marginal mandibular branch, which is your mentalis muscle. Mentalis muscle is down here. And then there's your cervical branch, which comes down and innervates some of the neck. Well, I think it's the platysma that actually is getting innervated. But we don't really, we don't look at the cervical branch. It's not really important to what we do in any surgery that we would monitor cranial nerve 7 for. Really, these 4 branches here are the most important. When you're talking about a skull-based procedure, you don't need to monitor all 4 branches. You can do 1 branch, you can do 2 branches, because you're at nerve root level, back here. So you take down cranial nerve 7 here, they all go away. So it doesn't matter, how many you're doing. If you're doing a parotidectomy, different story, because now you're out where the nerve's already split into its branches. So just 2 different techniques. So, but in skull-based, you can get away with, if you don't have the channels, you can do 1 cranial nerve 7 muscle. If that's all you're doing, and we'll get into, there's some different things you can do with cranial nerve 7, but if you're only doing EMG, you get away with 1 muscle in a posterior fossa. So it's very close to cranial nerve 8, and I'll play the video again. It's very close to cranial nerve 8 in the petrous temporal bone, the internal auditory meatus, cranial nerve 8's right here, and I'll show you how close they are in a second. It emerges through the stylomastoid foramen, which is going to be right around here. Passes through the parotid gland, so here's a parotid gland. Divides into its branches, and again, we can monitor all of these muscles: frontalis, oculi, oris, mentalis. So this is where we place our EMG electrodes. I don't typically reference them off each other. I do individual muscles for this. But that's where you're going to place them. So let me show you how close they are to the 8th nerve, the proximity. Cranial nerve 8 is highlighted here. So cranial nerve 7 is the one that's not highlighted. And I'll kind of show you what's going on. So this is the temporal bone here. There's cranial nerve 8. And cranial nerve 7 is the one that's not highlighted. So they're a complex. They're together. See how close they are? That's 8. That's 7. Just kind of give you an idea. This is why when you start getting down to acoustic neuromas, cranial nerve 7 injuries are very high risk. Any questions? So the process of hearing involves sound waves creating mechanical motions that cause fluid in the ear to move in waves and trigger nerve impulses that the brain interprets as sound. The outer ear functions as a funnel to funnel sound waves. The vibrations from these waves reach the middle ear and move the tympanic membrane, often called the eardrum. This causes 3 bones called the auditory ossicles to also move. The bones make contact with a fluid-filled structure in the inner ear called the cochlea, and the mechanical movements of the auditory ossicles move fluid inside the cochlea. The fluid waves move hair cells that line the cochlea, and the movement of these cells activate nervous system receptors. Signals are then carried through the vestibulocochlear nerve, this is cranial nerve 8, to the temporal lobe of the brain where they're interpreted as sound. So this is what's going on as we start to get into cranial nerve 8, the vestibulocochlear nerve, and we start discussing bears. So vestibulocochlear nerve, pure sensory nerve, originates lateral to cranial nerve 7 in the CPA. And again, it's basically 2 nerves, your auditory nerve and your vestibular nerve. So it senses sound, rotation, gravity, balance, and movement. It splits into the cochlear vestibular nerve, like I just said, and emerges from the medulla and enters the inner skull via the internal acoustic meatus. So here's the acoustic meatus here. It's a little hard to see as we come around. There's the meatus there, and there's the 8th nerve. So we monitor brainstem auditory vote potentials, however you want to call them. Brainstem auditory vote responses, auditory brainstem responses, so BARES, BAEPs, ABRs, whatever you want to call them, that's how we monitor them. BARES are not only used, though, to monitor cranial nerve 8, they monitor brainstem integrity and retraction of the cerebellum for cranial nerve 8 integrity. And they're utilizing craniotomies where cranial nerve 8 or the brainstem are at risk, and this includes the posterior fossa, CPA, a microvascular decompression, tumors of the 4th ventricle, so on. And we're going to get into that. But basically, BARES have 7 waves. Wave 1, and we're kind of looking at a different view of the brainstem here, right? So here's the 8th cranial nerve here. Here's the cochlea. Wave 1 is generated at the 8th nerve, distal 8th nerve. Wave 2, they're not really sure wave 2 is generated. They think it might be maybe more proximal 8th nerve, possibly cochlear nucleus. So somewhere between wave 1 and the cochlear nucleus is where they think wave 2 is occurring. Wave 3 is between the cochlear nucleus and the superior olivary complex. Wave 4 is thought to be in the lateral lemniscus. So this doesn't even show wave 4 here, but wave 4, this is like 4 probably here. So in the lateral lemniscus, and then wave 5 is thought to be generated in the inferior colliculus. Wave 6 and 7, they don't know if they're generated, above the inferior colliculus, maybe in the thalamus, maybe in upper, higher auditory pathways. They're not really sure. We don't really monitor for wave 6 or 7. Really 1, 3, and 5 are most important intraoperatively. This shows it again. So again, cochlea. Wave 1 is the distal 8th nerve. And wave 2, somewhere in between the 8th nerve and the cochlear nucleus. Wave 3, between the cochlear nucleus and superior olivary complex. There is a decussation. Wave 4 and 5 occur contralaterally. And then wave 6 and 7 might be the medial geniculate nucleus in the thalamus, or they might be higher in the auditory pathways. Setup is key to bears. Because you all know that there's the tubes, there's the ear inserts. You got to keep them safe. And as you can see, I'm a fan of tape. This keeps everything out of the ear. Now you have to be aware though that if you're going to do a posterior fossa, you don't want the tape to get in the way, because what happens, surgeon comes and rips it off. And what happens when he rips off the tape on the ear? Everything you have in the ear comes out of the ear. So this was a case we were able to be extremely excessive with the tape because they were not going this wasn't a posterior fossa, this was a third ventricle surgery. But you can see we have a ton of tape here. And this is just the last layer. You're not seeing our first layer of defense is once those ear inserts are put in, we take bone wax and we stick it in the ear. And we encase basically the ear insert. You want to make sure you don't occlude it though. You don't want to impinge it. You just want to encase it. And then we usually take tegaderms and we stick them in the ear and we kind of layer them 3, 4, 5 tegaderms out. And then from there, we go to our silk tape. But setup is key. Bears can be affected by trauma caused by mechanical, thermal, ischemic. Generally, your montage is going to be an A1 to CZ and an A2 to CZ. I believe our machines compensate for the 0.9 millisecond compensation for those tube inserts that come out. Stimulus intensity between 90 and 95 decibels of normal hearing level, with a masking noise about half that. Stimulus rate anywhere between 11.1 hertz, 26.3 hertz. You have to manipulate your settings accordingly to get the best bear waveform. Here's a filter, low frequency filter 30 to 100, and a high frequency filter 1500 to 2000. Guys, why do we use a masking noise? Right. You don't want to get bone conduction from the other side because it's going to, basically, you won't be able to see pathology if you get bone conduction because you're going to see the other side. So, interpreting BAP changes. In the operating room, the task is to detect changes in the auditory potentials from a baseline recording done after the patient is put to sleep, but before the operation begins. If possible, the observed changes should be related to specific manipulations such as stretching, compression, or heating neural tissue, and the anatomical location of the structures, the function of which cause the changes should be identified to the surgeon. So, you know, if you start seeing a shift out, it has to correlate to something. It has to be, they have a retractor in, they're using a burr, they're using cautery of some sort. There has to be some kind of mechanism for the change. It's not just going to be, a random change. Loss of all waveforms indicates some type of damage to the distal eighth cranial nerve or ischemia to the brainstem. Loss of waves 3 to 5 indicates loss of perfusion to the brainstem as well, or trauma to the nerve proximal to the distal eighth nerve. So you can still have that action potential and lose 3 and 5. Increased latency or loss of wave 5 could be caused by retraction of the cerebellum and subsequent stretching of the eighth nerve. And we basically use a 1 millisecond, 10% latency increase for alarms. And then 1 millisecond interpeak latency shifts are also cause for alarms. And then amplitude changes 50% or greater, but latency is more important than amplitude when it comes to bears. And this is just showing you what a bear should look like intraoperatively on the Cadwell. Green is baseline. This is actually a very nice one. You can see everything here. So wave 1, 2, 3, 4, 5. So you see the 4, 5 is a complex. Sometimes they're separated, sometimes they're together. A lot of times you'll see the 4, 5 split better on the contralateral side. You kind of see that here. But sometimes they just come together. So you have to be aware of that 4, 5 complex because it could change. If they are together, it could change your latencies during the case. So just want to be aware of that. So increased peak latencies from all waves, something occurring before the eighth nerve. So if you have all of your waves start to increase, it could be something happening in here, some kind of conduction issue. Maybe fluid got into the ear and now you have some kind of blockage, for your ear inserts. Something's happening before here. So increased latencies from waves 3 and 5 with a normal wave 1 is an eighth nerve injury. So they're working over here, they damage the nerve here. This is still working. Distal nerve is still working. You're still getting wave 1. Wave 3 and 5 shift out. Increase in wave 5 only. This could be functional changes occurring higher in the auditory pathway. Could be perfusion related, and it could also be retraction, stretching of the nerve. I've seen where wave 5, where they've retracted cerebellum, and the only thing that kind of started shifting out was wave 5. And that's just because they're probably causing pressure on the brainstem itself at that point. So latency changes have been favored over amplitude changes as indicators of injury to the auditory nerve. The ABR peaks are less variable than the amplitudes of the latencies are less variable than the amplitudes. So this is showing you a shift of wave 5 starts going way out. That was caused by compression of the brainstem and retracting the cerebellum. As soon as they basically took off the retractor, it came back to normal. And also, if you notice, we've also lost it on the contralateral side. Again, brainstem. You could lose both your wave 5s, with a brainstem compression. So, as you can see here, shifts out. They took the retractor out. Again, you have to correlate it to a change. We knew they had the retractors in. Everything was fine. It was going perfectly. And then this wave 5 started to shift way out. And we said, hey, do you have your retractors in? Sometimes you can't see what they're doing. And they go, yeah. And we tell them. And they took the retractors out and everything came back to normal. So just be aware of that. Transient latency increase could be due to drilling, irrigation, retraction, surgical irritation, hypotension, positioning. All these things can affect your latency, so you have to be aware if it's transient, it's going back and forth. They could just be there working, and bears are funny that way. They're not. You would think for modality that's not affected by anesthesia, it's affected by everything else, and they move around a lot.